Okay, you should be up. There you are.
Great. So welcome to the latest presentation in the National Telehealth Resource Center webinar series, providing timely information and demonstrations to support and guide the development of your telehealth program, presented on the third Thursday of each month. On the next slide, you'll see a map that shows that we are located throughout the country. The 12 regional telehealth resource centers, supported by 2 national telehealth resource centers, serve as focal points for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. On the next slide, you'll see that our presentation today will be on rural HIT, telehealth, and technology challenges, perspectives from the field. Our presentation will be a little bit different than our usual webinar series in that we're not going to have one presenter flipping through a bunch of slides, but we're going to have 3 great presenters or panelists who will be engaging in an interactive question and answer. We have a set of questions that we've already pre-prepared for them to answer, and so I will be guiding them through these questions, but we are very, very open to answering your questions as you come up with them. And really our purpose of this webinar is to really introduce people to the challenges that are really faced by rural providers right now, related to HIT, related to telehealth, and related to technology in general in healthcare. And so without further ado, I want to introduce our 3 presenters, and they come from a variety of perspectives and a variety of settings. Howard Chapman has been involved in healthcare management for over 36 years in rural community health centers. He is at a FQHC. He served 3 years as the finance manager and 28 years as the executive director for Southwest Virginia Community Health Systems in Virginia. He's also served as director of programs and development for the Tri-Area Community Health Center for the past 5 years, and that's another community health center, FQHC. Howard has worked in telehealth through a partnership with the University of Virginia's Office of Telemedicine for the past 16 years. In 2003, he testified before Congress on the benefits of telemedicine and distance learning in rural areas. He's also served on Virginia's Technology Task Force and serves as treasurer for the Virginia Telehealth Network. He has also served on a regional health information exchange board for Southwest Virginia and East Tennessee. So all in all, he's had a ton of experience in this telehealth and HIT landscape in rural areas. Tricia Prickle is the Director of Information Systems at Margaret Mary Health in Batesville, Indiana. Tricia joined the hospital in 2008 and has over 25 years of experience in the IT field. Tricia's leadership and passion for healthcare technology has assisted in the deployment of advanced clinical applications that has helped improve efficiencies and quality of healthcare at Margaret Mary Health. Tricia has successfully led the implementation of many critical initiatives, including implementation of the hospital's Health Information Exchange Initiative, CPOE, rollout of Health Connect, a community-wide personal health record, allowing patients to receive results directly from Health Information Exchange, and meaningful use initiatives for Mary Margaret Health. Prior to joining Mary Margaret Health, Tricia was Vice President of Information Technology at a financial services company. And Dr. Carrie Pelikanis is a family nurse practitioner with over 25 years experience in family medicine in the military, occupational, and rural health environments. She's developed several state and federal grant-based telehealth programs incorporating rural telemedicine and remote patient monitoring in a variety of patient settings. She is currently at the Chrisfield Clinic Family Practice in rural Maryland. And so without further ado, let's go ahead and flip to video, and we will start with our first question. And I think the question that most people and many people ask is this whole issue about broadband connectivity. It's pretty much a prerequisite for the effective use of health information technologies, from telemedicine to remote patient monitoring to electronic health records. So what would you say are some of the challenges with connectivity in the rural areas where you are? And we can go ahead and start with Tricia, and we'll go around.
Sure. From Margaret Mary's perspective, luckily we've been very fortunate to have fiber connectivity to all of our healthcare facilities, even our rural health clinic. What we have found is that this always takes time, so we have to plan far in advance for new locations, work closely with our local providers. For example, our rural health clinic did take us about 18 months to actually get connected to back to our hospital. But with a lot of hard work, we were able to get them connected. Another challenge that we tend to run into is, although that we are in an area that is covered by wireless connectivity, our patients may not have access due to cost. This has been a challenge for us in continuing to focus on patient engagement with our health portal, especially at our rural health clinic area.
Great. And Carrie, I think we lost Howard somehow, but Carrie, go ahead.
I can tag on to Tricia's. I am in a rural facility and in a very remote part of Maryland. Ironically, the window that you can see behind my head is approximately 50 feet away from broadband access that goes down the main highway in my community, but no one in my community has broadband connectivity because the broadband, we only have one telecommunications company in our area that has broadband capabilities. And because we're a rural area that has no economic infrastructure that is attractive to them, they will not connect anyone to the broadband. So I operate in an area where broadband exists, but we can't connect to it. So we've had to get very creative about finding alternate ways to allow for connectivity. And I've worked with a company locally that we've come up with some innovative ways to marry things together to make mimic broadband. And then, as Tricia pointed out, I do also have the added problem of my patient clientele not having internet access because of affordability and also accessibility in the area that I serve.
So as we wait for Howard to join on, we can go on and talk about, we're living in an era where over 90% of U.S. adults own a smartphone, and wireless internet is seen as a necessity for modern life. In healthcare, we're witnessing tremendous growth in direct-to-consumer models of care, the use of telehealth during emergency transport, and an explosion of remote patient monitoring for chronic disease management, readmission, penalty avoidance. I mean, all of these things require wireless and broadband to the home or en route. Do you feel that rural areas are particularly challenged in being able to keep up with these types of care models? Why or why not? And what are you seeing in your patient population?
What I'm seeing more often is our patients are beginning to expect these types of services. Convenience is becoming very key for our patients. I feel, again, at Margaret Mary that we have been very fortunate to utilize grant funding, as well as work very closely with a lot of our tertiary hospitals on implementing new technologies, programs, and services. But in some areas, I feel because we are small, we are actually a little bit more nimble and can move pretty quickly without a lot of roadblocks compared to some of our larger hospitals. I think one of our largest challenges we run into, though, is resources. Because we have a small amount of resources, they can be spread very thin in trying to implement many of these technologies.
And I'll go back to the same issue I dealt with before. Ours is about resources as far as affordability and access. In my community, not the entirety of the area even has telephone capabilities with wireless capabilities because we don't even have the infrastructure to support wireless access in all areas. And then I currently operate in the poorest and unhealthiest county in the state of Maryland. So many of my patient population have smartphones, but their service is provided to them either through Medicaid or Medicare, and they don't have the web-enabled or the full spectrum of smartphone technology. So they may only have text-enabled servicing and limited telephonic communication, which definitely inhibits the ability to use some of the more robust systems out there.
So have you seen some effective solutions to this whole broadband and wireless connectivity issue in rural areas where you are? And what are some things that could help with broadband connectivity in rural America?
Well, I can tell you that, one of the things that we did here to create or mimic a broadband system in our clinic was we took two DSL lines or two cable lines and married them together through a system called a bonder that a local telecommunications assistance company helped me with. So I took two 10 megabyte lines and created a 100 megabyte line by marrying them together. So I actually have broadband capability within the clinic that isn't accessible within my area. as far as our patient population goes, we are learning to shy away from the Bluetooth-enabled technology for remote patient monitoring and go more towards text-enabled secure message technology. And we're finding that we have to do a lot more marriages with call center type environments with monitoring, so that those patients that either are not capable of texting or don't have the minutes to do it, we can reach them through standard telephone lines. And then for our remote distance technology, instead of relying on traditional broadband, we're looking at microwave radio frequency technology for creating antenna-based towers into areas where this doesn't exist.
Great. From Margaret Mary's standpoint, we are actually very fortunate that we do have wireless accessibility in most of our areas. I think our biggest challenge really is that this comes with a pretty high cost for our patients, which a lot of times puts them in a situation where they don't have wireless capability. We do offer some similar services from a call center standpoint. And again, working very closely with our local ISP provider to continue to broaden the connectivity to make that more affordable for patients as well.
Carrie, we got a question on the Q&A specifically for you. With the ACA, don't you need redundancy for issues such as power outages? And do you have that with your hybrid broadband solution?
Yes, I have. I refer to my system as the Franken system. I actually have DSL capability through, I will use brand name Verizon is our local DSL provider. And then we have Charter Communications, which provides our cable services. So my 100 megabyte system is bonded with 2 Charter lines coming in. And I use my Verizon DSL as my redundancy. And then we actually even have a tertiary line of using Verizon hotspotting if we have to, because we have a full, fortunately you can't see my desk right now, but we do work in a paperless environment, haha. So we have the EHR as well as our telecommunications and telehealth and remote patient monitoring systems. So we try to have as many built-in fail-safes as we can.
Great. Are any of you utilizing the Universal Service Fund to support your broadband?
I tried.
Yeah. We do for all of our remote offices, and we have been, like I said, been very fortunate. We have recently been able to connect all of our offices, and we use that funding for all of our locations.
I tried to. I actually had an active RSP out there, but no one responded to it. So again, it's an issue of being in a very remote area that you can have approval for the USAC or RAC funding, but if you don't have a service provider willing to provide, you just have an approval.
Right. So one of your key issues is also finding providers who would be willing to provide the service and the lack of competition in rural areas.
Yes.
All right, let's shift gears a little bit, and if Howard joins in, we'll let him comment on broadband, but let's shift gears a little bit to workforce issues. Another fundamental building block to effective use of health information technologies is a workforce that's trained to effectively use, install, maintain such technologies. What would you say are some of the challenges rural areas face when it comes to healthcare workforce and using these technologies? And these issues could be related to recruiting qualified professionals, staffing, turnover, career development opportunities, pay scale training. It could be a number of things.
A couple of our biggest challenges are probably the frequency of utilization and retraining our staff when there is turnover. Because we are a smaller hospital, some of the technology that we have implemented is not utilized on a daily basis. For example, our telestroke has been greatly adopted, but we only have the opportunity to use that maybe 3 to 4 times a month. So that makes it very challenging as when the equipment is pulled out, the staff having to remember how exactly do I utilize this. If it hasn't been utilized for a while, making sure that everything is working appropriately. Also, many times we've had vendors set up our equipment as part of a grant funding. So making sure our technical staff has been trained on that equipment, and as well as turnover on the technical staff and making sure that they've been trained and kept up to speed on that equipment.
And I would say in my environment, we don't have as high a turnover as you would see in more urban areas, because there are not that many available avenues of alternate employment than what we have. But one of the things that I had to do as I was looking at varieties of technologies is trying to get as user friendly as possible on our end, so that anybody at a minimum capability of educational level could be able to utilize equipment. For example, I have some equipment out on an island out in the middle of the Chesapeake Bay that is 12 miles by boat away from me, and there is no road access. So when they are providing service from there, I have to rely on the individuals on the island, and I did hire somebody part-time, but there is obviously no one with any kind of, I shouldn't say obviously, I was unable to locate anyone with an IT background living on this island of fishermen, so I just trained the fishermen how to fish with telemedicine instead of
That's terrific. And Howard, looks like we got you back on.
Yeah,
so let me flip back
I dropped off for a little bit.
to the broadband issue.
You want me to talk about the broadband stuff since I missed that?
If you could talk about the broadband stuff. We just switched over to workforce, but if you could give your comments on your broadband challenges, that would be great.
Yeah, we're like most of you guys. It's a real rural area out here in Virginia. The mountains actually block that line of sight signal, so a lot of times wireless sort of jumps over that. Most of the cell towers out here are in the highly populated areas or towns. After you get off the interstate corridors, you really have no access. So in my office, if I get a bar, maybe 2 bars, it depends on where I am in the building, whether I can take a call or not. And from the standpoint, though, what we're finding is we've been working with the University of Virginia trying to do a home monitoring program. Some of the devices we've tried actually shows we're getting a signal, just can't get the connection that we need. So whether they're just not as sophisticated as some of the cell phones and being able to pick up that signal or not, but we're having some issues with that. And again, the one thing that I've found is, and Kathy's probably familiar with this, the Virginia Tobacco Commission, which were the settlements from the tobacco industry a few years ago. One of the things that they've done is actually put fiber along all the major highways in their area. So when I joined Tri-Area about 5 years ago, they had pretty much a T1 line that was the connectivity, and really unreliable. It's a slow connection. And we told them, we said, I think you got fiber on the lines up along Highway 58. And it did cost us a couple of $1,000s to hook up, but we actually were able to hook to that fiber. So a lot of times it's just knowing what's out there. I think there's a lot more things in some of these rural areas. It's just, it's not made real clear, and it's still not made clear. The Tobacco Commission don't promote it. And as somebody else noted, a lot of these carriers just not interested in some of the connectivity in some of these rural areas. So it's hard to find a vendor that's willing to come in and do that. But we already were using Universal Service Administration, so our current vendor was agreeable to looking at hooking into the fiber, and so we were able to do that. And like I said, it has increased our speed, it's increased our reliability, so it's been a great connection.
Yeah, it's interesting that, I think in rural areas there probably is some fiber that people don't know about. We know with some of the grids that there are some things that just need to be lit up that aren't lit up. And a lot of the challenge is that communication and the coordination, and, left hand doesn't know what the right hand has done. And so there isn't that coordination in a lot of these rural areas. So Howard, what are some of your thoughts about workforce issues? We had just talked about, the effective use of HIT and technologies requires kind of a trained workforce. And we've heard a little bit about some issues with turnover, particularly with training and, you know, with staff who don't use the equipment quite as much because there just isn't quite as much volume. Oftentimes it's difficult to keep them sharp and able to use all the equipment when it's needed. What are some of your experiences with the workforce issue?
Well, we've had 5 people trained through that STAR program that actually it's a certification program for using telemedicine equipment and just being a little more familiar with it. I see telehealth and the technology being a real recruiter for things like hiring physicians and some of the more scarce resources that you can try to bring to some of these rural areas. Actually puts the resources of a major university right at their fingertips. So the rural isolation that they face from being out in an area where everything's not readily right next door, I think it helps you recruiting wise and things of that nature. The University of Virginia, who is one of our premium partners, they give us access to 24 separate specialties. Being in a state-funded institution, they see people on a sliding fee scale basis. So it's been a great relationship for us. We're actually doing some of the diabetes education programs, have a digital retinopathy camera to be able to do the diabetic screenings on patients. The one program we're working with right now is a diabetes quality improvement program that uses an endocrinologist, but actually a home monitoring device that, again, will summarize all the various readings from that glucometer, their daily dietary intake, their exercise and that type of thing, and then gives him a graph. So he takes a patient for 6 months, gets them better in control, and then turns them back over to us.
Great. So you're actually seeing that the technology is actually helping your workforce challenges in terms of recruitment.
It is. And again, I think having a provider champion is important to doing that. Otherwise, if you can't sell the providers on it, it'll sit on the shelf and it'll collect dust. But having a provider champion and them seeing the value of services you're using it for really makes a difference.
So Tricia and Carrie, are you also seeing that having a champion is really important for your workforce challenges? And also, what are some other things you've seen that have mitigated some of your workforce challenges?
For us, making sure we have our physician and clinical involvement has been very beneficial for us. And I think, as Howard said, having a physician champion and help, utilizing them to really drive that technology utilization has been a great benefit for us. A couple of the other things that we kind of did to kind of mitigate some of the challenges that we had is making sure that we have a good process set up, good documentation set up for the technology once we implement it, making sure that we're regularly changing or training our staff members, whether that be through kind of in-service training sessions, and then on our IT side, making sure that we have good processes for keeping up that equipment in place, an area to troubleshoot if there is things that do come up. So we implement like a solutions database to allow when issues arise, they may only happen every, once or twice a year. Our team can go search for those issues and be able to see, okay, the last time this happened, this is what another team member did to correct the issue.
And I think another thing that I would say along the workforce line that has helped me is one of the programs that I have right now is a combination of telehealth carts with community health workers. And what I've done is the community health workers were trained via our area AHEC, and they're also able to communicate with community health workers throughout our region. And that helps them to stay connected with folks who are not doing telemedicine, but also be engaged in community health. And actually they end up being just as much a champions as I would say the providers are, because they're out there spreading the word to not just the patients, but other folks that are in their same job categories as to what they do. And we're also very fortunate that because we're so rural and remote, we're asked to beta test a lot of equipment before it goes live. And so I think my staff in general is very flexible because they're used to taking programs that are new to the market and working the kinks through on them So when they get something that is established, they're easily adaptable to it.
So as rural health providers, are you guys open to beta testing? Are you open to vendors saying, hey, we've got something that we think will work in rural communities. Would you be willing to try this out?
Well, as a result of being active in Matrix for many years now, I seem to be the go-to in the state of Maryland for rural health beta testing, because really there's very few people that can match our type of rurality, and that we have the rurality of location as well as servicing these islands that don't have road access. And so, yeah, actually, I've loved being a beta testing site, and I'm approached by many people. I find that oftentimes I have to say no because I know what they need in order to make their system work, and we just don't have it here. So we try to only beta test for those entities that we can really provide a resource for, or if they bring systems in that require a lot of interactivity with the patients on a Bluetooth level or on a wireless level, I have to admit to them that more than 40% of my population doesn't have wireless access because of, similar to what Howard said, we don't have the mountains, but we have no tower connectivity. So there's no point in me beta testing something that would require wireless activity.
Tricia and Howard, how about you guys? Are you open to beta testing things?
I think we are, from the standpoint of, like I say, we do a lot with UVA, and a lot of theirs are through grants, and they'll do it as a pilot. So we do some of that primarily as the funding's lined up. But and it's been a pretty easy sale, like I say. Once you get the providers on board and they can see the benefit, it's a lot easier to do that.
For Margaret Mary, we're kind of the same way. We end up a lot of times being a test site for our tertiary hospitals. I think because we are small rural hospitals, like I said, sometimes it does make us a little bit more nimble and able to move more quickly to actually implement and trial out some of these technologies.
All right. Let's shift the gears a little bit to, we do have a question, I think. You want to go ahead and jump into that, Beck?
Sure. So someone, and I just have a feeling that they work for a vendor, any suggestions for how you get approached for beta testing?
Well, I have to say my most successful vendor probably caught me on a bad day. I wasn't paying attention when I said, sure. Because I test the vendors by saying, sure, if you want to come down and talk to me, I'll be happy to talk to you, knowing that it's probably going to be a minimum of a 3.5-hour drive from the nearest airport for them to get to me. So it kind of shows that whether or not they're truly interested. But you know, a lot of times I will have them email query us, and then we'll follow up on an email. And I usually in the email ask them to elaborate what exactly they're trying to obtain from their testing and whether or not we're a good fit for them.
And ours is usually driven by UVA or somebody else that brings the proposal to us. So again, they've already sought funding and that type of thing, and that's where it comes to us.
Yep, ours is very similar to that.
Okay, great. So let's switch over to electronic health records. A significant amount of resources has been invested in rural areas over the past decade to make sure rural providers are able to achieve meaningful use. What have been the greatest successes you've seen in your rural areas in this regard?
From Margaret Mary's standpoint, we were actually, I think, pretty, we're currently have met stage 2 for meaningful use. And I feel kind of as the rules came up, we were fairly prepared when the regulations came out. We already had an electronic EMR. We're performing electronic documentation and had rolled out CPOE to our providers. Our biggest area where we had to focus on was patient engagement. And I believe from our standpoint, our biggest success was that we had just started down a path of evaluating a hospital-sponsored community-wide patient portal that was kind of EMR agnostic. And fortunately, during this time, ONC was funding a program to figure out how to get HIE data actually into the hands of the customers. So we had a great relationship with our regional health information exchange, and we're able to partner with them along with our portal vendor to participate in the ONC grant funding to really make this project a reality for Margaret Mary. This gave our patients in our community one place to go, one place to access their information, organize their health information, manage shared information coming from the hospital, our community providers, and then by feeding the data in from our HIE, they were able to get information from our tertiary hospitals as well, allowing them really one place to access their information. And I really feel like that was a great success for our community.
That's phenomenal. How about Carrie or Howard?
Well, from our perspective, Community Care Network of Virginia, which is our health center control network, pretty much took that on as a challenge several years ago. And actually, the initial funding come through HRSA. And we had 20 of the 25 community health centers in the state that all went with the same unit or the same vendor, eClinicalWorks. But we had probably 5 of them that went out on their own with different products. And, we've seen them, and the organization I work for now, Tri-Area Community Health, is actually one of those that went with another vendor and another EMR. Tried that for several years, could not achieve meaningful use under that system, and changed back over to eClinicalWorks and were able to do that within 6 months. So, but the things that CCNV bring to the table is they've got a couple of on staff. They've got a couple of programmers. They've got their own trainers. They're doing some of the clinical improvement things for the HRSA clinical and financial measures. So again, they've got a lot of resources they bring to the table, and that's really helped us a whole lot. We're currently moving toward the stage 2, but like I say, we've already achieved meaningful use through stage 1, and then the extra money that through CMS has been a big help to do that.
Right, Carrie?
I think the most successful thing is me not quitting the profession. I am on EMR number 3 for the clinic, but I've probably used about 9 different EMRs in my career. I feel like we're doing an advertisement for eClinicalWorks, but that is who I use. I use eClinicalWorks for a little different area. I'm the white elephant of independent private practice, not associated with a hospital, and eClinical actually awards me for the cost of the service most robustness in meeting meaningful use, PQRS, and all of that. And so it really became, we chose eClinicalWorks on a cost effectiveness standpoint, but it's been perfect for what we're looking for. And we're at stage 2 attestation already. The patient engagement, I want to come live with Tricia. That's where we struggle the most because our patients don't have the access to it, but we're trying to get creative on that. But when I opened this clinic 5 years ago, I opened it as a EMR-based paperless clinic, and so I think that has made it be very easy to just continue to migrate on. It just took us 3 iterations to get to where we are now. And we've been with eClinicalWorks for about 3 years now, so I find it fairly adaptable.
Great. So you already started talking about some of the challenges, patient engagement being one of them. Are there some other challenges, or do you want to elaborate a little bit more on that one in terms of interoperability, the health information exchanges, direct messaging, dealing with legacy systems even, or costs, investments, upgrades? I mean, all of those things related to keeping up, maintaining, and moving forward in terms of your EHR implementation, your meaningful use, kind of moving to the next level.
Well, I could say, Howard pointed out the reimbursement from CMS. As a nurse practitioner, I'm not eligible for CMS reimbursement. So that's been a challenge. And in many rural facilities, there is not a physician necessarily on staff that provides that ability for reimbursement. Now, we're fortunate in the state of Maryland in that they do have a Medicaid reimbursement for EMR use. So we are able to get some reimbursement on that end. And then challenge-wise in the state of Maryland, and I forgive me if anybody from the state of Maryland is a participant, but I am frustrated constantly by our state information system, CRISP, because it's not very interoperable within the systems, but they are working to improve it. And then in our area, in the greater area that I service, there are so many different EMRs utilized by the specialists and the hospital groups within our area that I'm not finding a lot of interoperability between yet. I think in the future we might get there.
For us, direct messaging was a bit of a challenge for us, mostly because our EMR didn't have their own HISP that was initially part of that direct trust bundle. So when we kind of began the transition of care and trying to exchange information with other providers in our community, that was a big challenge. It took us about 9 months to get through kind of that hurdle to be able to really start exchanging that data. And then once we have, just really trying to work out the best workflow for those transitions of care electronically has been a challenge. One of the other challenges I think we also had was just with a small number of staff members to be able to implement all of the meaningful use changes, along with keeping the lights on, the day-to-day operations, as well as other projects, conflicting projects, pulling those resources in multiple directions.
And I think for us, again, the interoperability, we don't have a functioning health information exchange out in this area. We had one that was working to serve this region in East Tennessee and Southwest Virginia, pretty much a full not-for-profit representation from various levels, from behavioral health, from pharmacy, from the hospitals and hospital networks, even the VA actually, and then through some national demonstrations allowed us to access their system. And when the VA trusts you to get in their system, it's pretty important. But the two hospital networks pulled away from that. We had been supported by some operational monies from the state of Tennessee and actually from the state of the Commonwealth of Virginia. When the two hospital networks backed away, the states pulled their funding, so we were left pretty much without any operational monies, and we had to drop that. But you see that a lot. People still operate in silos, and even in some hospital networks here, various departments and various specialty networks within that hospital network don't communicate with one another. And it really is a shame. I think all the money they're throwing right now towards some of the opioid abuse, if you had a good functioning health information exchange, and when that patient went to the emergency room last night and got a narcotic prescription, you can keep up and monitor and maintain that. And I think a lot more money could have been thrown into a system like that. Would have been a better coordination of care for pretty much all the providers and all the practices that are out there in some of these rural areas.
Absolutely. I think those are, challenges throughout the nation, but definitely in rural areas, that's a huge challenge, especially with narcotics and opioids, and just how big an issue that is, particularly in our rural regions. So let's switch to our next topic, which is telehealth equipment, peripherals, payment models, reimbursement, all those things that really are required to run a telehealth program. Rural areas have been particularly blessed with ability to obtain grants because a lot of the telehealth grants are specifically earmarked for rural areas. Have you found that grants have been a good way to jumpstart your telehealth efforts? And what are some of those grant-related telehealth successes you've seen?
They've been great for us. Most of ours have been driven by grants. We've looked for other sources, though, and if they wouldn't fund something in an urban area, I've gone to somebody like the Virginia Healthcare Foundation who would provide funding to go into that. We've actually gotten money through the Virginia Department of Housing and Community Development, which again had a rural focus. But I think there's money from ARC. There's been money through the HRSA and the rural health program that they have out there, which you have to bring at least 3 collaborating nonprofits together to do some of that. But I think there's still a lot of sources, but as you point out, a lot of it's still driven by a rural connection.
From Margaret Mary's standpoint, we also, most of our telehealth experiences have been jump-started by grant programs. It's basically, for us, has helped us to, get the initial funding to start the program up, and allow, we use this for our telestroke equipment. We've also used grant funds to start a community-wide patient portal. So for us, the grant funding has definitely assisted with getting these projects moving in the right direction. Many of these we kind of hear about being involved in our rural health associations, state associations, community groups, and again, vendors approaching as well as our tertiary hospitals, kind of, again, utilize us kind of as a starting point sometimes as well.
And I've had similar experience. I 2 years ago wrote a USDA distance learning and telemedicine grant for the equipment that services 9 of the facilities that we have telehealth carts on. And then I started stacking and leveraging one grant against the other. I went to HRSA for a rural outreach service grant to provide the community health workers that would marry up with the equipment that I was able to get through USDA, because that's an equipment-only grant. Then I went to the state and did a small pilot grant with remote patient monitoring that opened up the ability to then again leverage the state back for some other grant initiatives. And as the other 2 speakers have said, I've utilized the grants to either in new projects or innovative projects or expand upon projects that we have. But the ultimate goal is to try to find sustainability through reimbursement. And each of us is in a different state, so every state's slightly different on that. But we are making strides in the state of Maryland. It's definitely a challenge, the whole issue of reimbursement. But I think there's a future to be had there for sustainable and buildable models.
Yeah, that's a great segue into our next question, which is, what are some of those challenges related to, after you get the grant? And whether it's upgrading and maintaining the equipment after your initial grant funds, sustaining the program after your grant funds, finding clinical champions once you get the grant funds. What are some of those issues that you've had related to either obtaining the grant or sustaining the program after you get the grant?
I think part of it for us, a lot of that technology has driven the cost of the equipment down. It used to be when we first started with UVA, one of those carts was about $65,000 to put that equipment in place. Now it's probably less than 20. So again, the changes in technology has driven the cost down. But, from the communication lines, which always have been a big part of the initial cost of doing any telehealth, you need that now for your EHR, for being able to connect and link to other people. So that's not really, it's calculated into the cost for other things that you need that for now. So really, I don't think there's a whole lot of burden on a system to be, to be a telehealth site. I think there's other needs that we need for the connectivity and the communication lines now, and telehealth is just one purpose we can use it for.
And I would say from the grant perspective, the biggest challenge or burden associated with a grant for somebody of our size is just the reporting and upkeep and constant need to meet especially to pick on some of the federal grants I have, but I find myself having to stop probably 10 hours a month to either create reports or report back to them about the projects that we're working on, which certainly they've given you money, so you expect that. But it can become burdensome if you don't have the extra personnel to be doing it. We were working last night on a report until almost 8 o'clock. So that does happen a lot. The other thing is that I think it's important for anybody that is looking at grant environments to realize that the grants, you can't sustain yourself with grants. You want to use the grant for a specific purpose, and then work towards sustainability outside of a grant-related environment. Because if you're working to sustain yourself by grants, you're constantly chasing grants and writing grants and not necessarily getting much done.
And I would agree, you know, a lot of our, what I would say, one of our biggest challenges, the upfront resource time and commitment in maintaining the grants, getting them up and going, completing the necessary documentation and maintaining that documentation for submission and auditing is probably one of the biggest challenge. But I completely agree. You know, that's kind of just the kickoff and the initial portion of that. Really making sure that you are sustainable going forward is the critical item that you need to focus on.
Well, we did have a question that was related to that, and maybe I don't know if any of you have had a challenge sustaining a program that was initially grant funded, or if you can speak to, you know, what did you do to keep something going that might have been a challenge to keep going?
I think the reimbursement end for telehealth has made it really challenging. You know, when we first started back in the early part of the 2000s, it actually is an interactive consult. So somebody's doing the exam, working the equipment and things on the originating site end, and then the distance site end where the provider is. And it was billed as an incident 2 through incident 2 coding. You know, incident 2 codes are still out there. They're still valid codes. CMS just elected not to recognize those codes anymore. So it cut out the ability to have much billing on the other side. And basically the originating site fee only covers for the use of the equipment and the communication lines. So started out with a flat fee of about $20. It goes up with the Medicare cost index about 3.5% each year. So it's up to around $27 now. But it's tough to sustain a program like that. So you really got to take and recognize the value that it brings to the patients. And, you know, for us, we got a grant to buy a digital retinopathy camera, and we do retinopathy screenings through UVA. We've had one person that actually was a preventable blindness through the screening and detection for doing that. So for that person and their family, I don't know how you'd put a value on that. But, you know, about 75% of the patients who are screening right now, or the ones we screened last month, needed a referral for other eye exams or other eye problems. So again, it's that level of value, I think, that brings a lot to the table.
And I think that's a great segue for our last question for this segment, which is how do you as a rural provider actually demonstrate return on investment? You know, as a rural provider, you do have to invest quite a bit, whether it's spending the hours writing the grant or figuring out in your business model, you know, how you sustain and upgrade the equipment and maintain and keep your staff trained. It is definitely an investment. So how do you, I guess, justify and capture that return on investment as a rural practice?
I think, you know, as a rural practice, it depends on why you're doing telemedicine. I think most of us do it because it's a passion that we have, and there's no price or return on investment for passion. And as Howard pointed out, we recognize the ability to overcome barriers that are not achievable in other methods or are more expensive to achieve in other methods. But it is a constant catch-22 with how do you prove that someone would have accessed care differently or more expensively than if you had not utilized rural health service? And so it's a constant problem of research of putting a cost on negative use situation. So that patient didn't go to the emergency room, therefore didn't cost X number of thousands of dollars. And it's something that I struggle with when I testify at the Senate level in the state of Maryland, because our Medicaid system only recognizes the tangible costs that come through, and therefore they live in perpetual fear of this mythical explosion of healthcare associated with telehealth. They're not seeing that these same individuals are utilizing the services elsewhere, and so the return on investment is actually in non-use, not in necessarily use of the equipment.
Yep, I would agree. That's kind of where we see that as well. You know, some of these investments are, you know, really ways to, you know, get care to your patients, but as well protect and retain your patients. For example, I think in some areas, telehealth visits are starting to be driven by insurance carriers and employers, so to keep expenses under control. So patients will, I think patients are really what's going to drive the technology to continue to grow, and it also becomes a convenience factor as well for many of our younger generations. If I can, for example, if I can get a telehealth visit, on a Saturday morning for a minor issue and don't have to wait until next week to be able to get seen in my provider practice, that's going to be a convenience for me. And I think wanting to make sure that we can offer those same services to patients in our community that other communities are offering is critical as well.
Yeah, and I think as we transition out from pretty much just a fee-for-service basis to pay-for-performance, and and they're saying by 2018 that's going to be pretty much the driving force behind how you're reimbursed. The ability to bring in the access to that specialty care, to be able to improve the patient outcomes, all that'll make a difference. But for us right now, I think some of the things we just hired a psychiatrist this past year. We're interested in being able to use that psychiatrist at all 3 sites through using telehealth. And Virginia is one of the progressive states that does reimburse for telehealth services. But there's a CMS regulation that actually prohibits FQHC or a rural health clinic from being a distant site. So we can't be the site where the provider is as well as the originating site. There's currently legislation in place to fix that. And hopefully if that passes, it does have some reimbursement for some of the home monitoring systems and programs out there too. I think, again, those type things will allow us to bring a little more revenue in and make it a better return on investment for using telehealth.
I would agree. From our standpoint, what we're looking at, is, if we can have a provider that can provide services to multiple different locations, that means that's that many more areas that we can get to and help provide service to our patients.
Yeah, Kathy, before we move off of reimbursement, we had a question, and I'll read the question. Are there any issues in telemedicine with traditional insurance reimbursement methods and practices, or do these services operate outside of that model?
I think it depends where you live. In Maryland, we have parity associated with telehealth. And so anything that is reimbursable from a traditional standpoint is reimbursable as a telehealth visit, with the exception, as Howard pointed out, of remote patient monitoring and those that are not covered by CMS. Maryland legislation and regulations follow CMS parity.
Yeah, and that pretty much is the same thing. Like say, most of the insurance carriers will go back to that CMS regulation or guideline. But in Virginia, our Medicaid program has been paying us based on using telehealth, and if we do bill as a distant site, they've been covering that. Most insurance companies will too, but again, they always have that fallback to go back to the CMS reg and say, if CMS doesn't pay you for it, we don't have to pay you for it. So it's an easy out for them.
Yeah, I think a lot of those regulations are driven by state. And I know, for example, with Indiana, here beginning July 1st, as part of telehealth visits, you can now do prescribing. So that is a big change for the state of Indiana as well.
Great. Before we take any further questions or comments from our listeners, are there any other pressing issues related to HIT or telehealth or technology that you feel should be brought out to our listeners so that they get a full picture of some of the challenges that you guys face?
I don't have any specific pressing issues, but I think from our standpoint, we would encourage, telehealth options, as I think there's a great opportunity in rural communities to actually provide these type of services, whether that be to provide access to additional healthcare providers, specialists, home care options, monitoring, or access to critical patient services. I think this is a great way to really help provide the care and services. And I think that's why so many of us are very passionate about healthcare and where technology can really help make a difference and improve the care that we provide to our individual patients.
And I think I chime in there that one of the main concerns that I had from my community at large, in the healthcare community at large, was that they did not feel the patients would be accepting of telehealth visits in a rural environment. In actuality, my patients live for them, and now will come in and say, well, can't I do that through telehealth instead of having to go to Baltimore or instead of having to go somewhere? So the initial fears that many of the folks in the outlying community had about the patients not being accepting, it's not there. It's if you build it, they will come. It's a field of dreams technology.
Yeah, and I think for me, the one thing would be it's that rural definition that's used by different federal agencies. And, you know, what we're seeing now is 2 of the 3 sites that Tri has, which all of them are rural, but because of the proximity to Blacksburg or to Roanoke, we've had 2 of our rural sites now that have been moved to the urban status, which again cut out your Universal Services Administration benefit. And I think that, you know, that really needs to be looked at. I think, again, population-wise and everything else, these areas are as rural as you can get. So, but I think, again, different agencies use different standards in assessing what's rural.
Great. So we will open our time to any questions. I don't see any active questions at the moment. So let me throw in just one real quickly. I know that we have some vendors on this call, and I am wondering if you have some advice for vendors who might want to penetrate the rural sphere, because many of them have focused most of their efforts and time in that urban or suburban setting. If you have some vendors that are really wanting to kind of enter into that rural community, do some things to assist in rural areas, what advice would you give them in how to get into a rural community and how to be of use?
I think you have to prove some value. And again, as we've noted throughout this presentation, I think rural is usually the opportunity for grant funding. So again, there's opportunities to have some initial startup and some of the things that, you know, could come from that. But again, it has to be driven by the value that you can bring to enhance your patient care, you know, improve those outcomes, and it has to be some value to the service you provide.
And I think another thing that I would throw in there is, as a vendor coming to a rural environment, realize that you're not going to have the lucrative opportunities that you would in a more urban area. Oftentimes vendors come to me and they either propose systems that are well outside the affordability of my patient population or our organization's ability. And also, I don't have the numbers because I am rural. Therefore, I'm not going to have the vast quantities of numbers they're looking for patient enrollment. Therefore, it may not be something that they're looking to have a monetary reimbursement that they're going to receive.
Yeah, and I think also keeping things simple and easy to support, because we don't have a lot of, from our standpoint, don't have a lot of extra staff to support the technology once it's implemented. We want to make sure that it is easy to support and able to be sustained for the environment.
Great, Becky, I know we have some questions. Do you want to go ahead and ask them?
Yeah, I've got a question. Is anyone partnering with public health for telehealth services? And if not, would you see any benefit in utilizing telehealth for public health integration?
We're not currently using doing things with public health and doing that, but you know, I would see some really neat applications that you could do with doing that. You know, but we're not currently doing anything with it.
We currently are not as well.
I'm not aware of any public health opportunities right now, but I certainly am always willing to partner with anybody who wants to partner on telehealth, communications, and technology.
Okay. Another question. It sounds as if Howard and Tricia have had good experience with their USAC funding. Were there any issues in taking advantage of the funding? And then for Carrie, were you approved but your incumbent wouldn't execute? Do you understand that question?
I do.
And then how would you guys suggest changing or improving the USAC process that would have allowed you to take advantage of the funding?
Well, the USAC funding's been great for us. Again, it's usually what they'll do is it's the nearest urban rate, and then it's like a 25% discount. So it really makes the cost of the connectivity much more affordable. But the new program for the Neighborhood Connect funding actually is a 65% straight discount, and where there were restrictions in the past, like a corporate office or a building office, you couldn't take advantage of the USAC funding or the Universal Service Administration funding. You can do that under the Neighborhood Connect program. So again, it's been a good program, and you know, and I will tell you, one of the things I think that we've seen is it typically is driven by rural areas. And one of the things Kathy and I have talked to a couple of different groups about, they're considering letting people form consortiums, which had to be majority rural, like 51% of it. But again, the opportunity for some urban sites to be able to come into that, to take advantage of that, would greatly enhance their ability to take advantage of some discounted rates too. So again, hopefully that can be something to be worked out in the future.
For
And
us,
I know
that's been
we're
a great.
about out of time, so I don't know if we want to stay on for the 1 or 2 remaining questions, or if we want to go ahead and flip to the final slides, and then we can shoot the answers to the questions out to people afterwards. What do you suggest, Beck?
Whatever you want to do.
I guess we can just stay on just real quick for the last question, and then we will wrap up.
Okay. So this one last question that we're going to take today, what is the standard structure of the telemedicine clinic? For example, an RN at the outpatient site and a mid-level provider at the originating site.
We've used mid-level providers in the past to do that. Basically, like say in the beginning, we actually got reimbursed through incident to billing. Since that's passed, and there really is no reimbursement for, you know, a nurse or nursing staff to do that, it really doesn't make a whole lot of difference. But you know, again, a nurse or somebody capable of somebody completing one of these STAR certifications can actually run that equipment and do very well with. They do recommend you have somebody with the equipment when you're doing any type of consult.
All right. Do you have anything else to add? Otherwise, we will flip to the final slide and just say that this presentation has been part of the National TRC webinar series. And the next telehealth webinar will be presented on ATA follow-up, answers to your most burning telehealth questions. And we're doing a little bit different format on this one as well, having a TRC panel of experts and just featuring Q&A for that whole time. So if you have Q&A, you can provide those questions when you register for the webinar. And we'd also love to get your opinion on this webinar. Your opinion is very valuable to us, and we want to work on quality improvement. So if you don't mind filling out that quick Surveymonkey Survey link that is on your screen, and I think Becky's going to put that in the chat box as well, so you can hit the link and go to that. We would appreciate it, and thank you so much for joining us today.
Thank you, guys.
Thank you.
Thank you, everyone.
Thanks.